Hello, everyone, and Happy New Year. We begin this new year with newly recognized resilience and innovativeness and new beginnings within various facets of our lives. I'm Vincia Pandian from Johns Hopkins University, and I'm here with Dr. Michael Brenner from University of Michigan, who's also the president of Global Tracheostomy Collaborative, and Dr. Amy Freeman Sanderson, a member of our GTC Education Committee. And we are delighted to welcome you back to our Global Tracheostomy Collaborative webinar series. Today, we're excited to unveil our GTC's third version of the Global Tracheostomy Database. Our Global Tracheostomy Database provides a foundation for clinicians and researchers to use data science to improve care of individuals with a tracheostomy. And so our panelists will present various changes to the existing database and its evolution, describe the importance of data science and tracheostomy management, theorize how findings from data could be translated into clinical practice, and how to strategically access and utilize the GTC database to experience its benefits. So our webinar today is sponsored by unrestricted educational grants from Medtronic and Smith Medicals. And I want to take this opportunity to thank them for their continued generosity. While our panelists are speaking, if you have any questions, please type them into the question section in the control panel, and we will answer your questions towards the end of the session. All information provided during this webinar will be to the best of our knowledge, especially in terms of the database. And if you have additional questions or if you need additional more specific information related to your institution, we would recommend that you go to GTC website. That's gtc.org to obtain more information specific to your needs. So today I'm really excited to learn more about our new version of the tracheostomy database, version 3.0. And so without further ado, I'll request Michael to introduce our speakers to get our webinar started.
Thank you so much, Vincia, and it's a pleasure to welcome you all to the first webinar of the Global Tracheostomy Collaborative in 2021. Our first speaker is Dr. Bradley Schiff, who is an attending physician in the Department of Otolaryngology at Montefiore and an associate professor of otolaryngology at Albert Einstein College of Medicine. His clinical focus is on cancers of the head and neck, specifically parotid masses, thyroid, parathyroid disease, larynx cancer, cancers of the oral cavity, neck and skull base. His research primarily involves improving the safety of patients with tracheostomies, although he has a wide repertoire of other research interests that variously involve fine needle aspiration and products on thyroid, parotid, and squamous cell carcinoma. He actually just in the past week or so had a paper published in JAMA Otolaryngology reporting his own institution's experience in approaching the COVID-19 pandemic from the standpoint of tracheostomy. And his work has been published in many journals and books, also presented nationally. He has been named as one of the New York Times super doctors from 2009 to 2021. Take it away, Brad. Thank you for joining us.
All right. Hi, I'm Bradley Schiff. I'm an associate professor at Montefiore Medical Center in the Bronx, New York. We're going to try to tape this because I am on call. I hopefully am also there in person, as I fully intend to be, but just in case something happened, we're gonna tape this part. So I want to talk to you guys today about the database version 3.0. We put a lot of effort into improving the database and a lot of effort into making this, I think, a much, much better version of the database. So I'm excited to talk to you about some of the changes we made and why we made them. And I'm excited to answer any questions afterwards. Okay, so why do we wind up updating this database? The first versions were created entirely by members of the GTC, and those members were generally clinicians. They were doctors, they were speech therapists, they were nurses, and everyone or most people were experts in trach, but none of them were experts in database building. And so the first two versions, they hopefully answered the questions that people were asking about trach, but they weren't necessarily designed in the most ideal way. And we wanted to have a platform, a stable platform, where we could generate useful data. We wanted to be able to add questions, to change questions, to modify questions without losing data. And we wanted this done in a way that would make it easy for people to enter data. And so we looked around, and there was a data coordinating center based at Boston's Children's Hospital, and it's part of the Center for Applied Pediatric Quality Analytics, or CAPQUA, and we got them involved, and they really made a tremendous difference. They were able to restructure the database, and they were able to have us phrase questions in a way that would get the answer and generate the data that we want. So I think that has been by far the biggest difference between the two versions of the database. So what do we change? And the most important ideas for improvement came from the members, came from you guys. And they, there were emails, there were personal communications, and then there were the way that people answered questions in the database. Every time somebody would email the GTC with a question about the database, something they didn't understand, or a suggestion, or something they wanted to add, we kept a folder, and we had years worth of these building up. And then anytime somebody communicated something that they thought should be changed or improved, we put it in a folder. And then anytime there was an answer in the database that maybe didn't make as much sense, for instance, if there was an other, and every time we looked through, if there were a lot of others, and said, what were people answering others? Why couldn't we give them the choices that they wanted? And if 17 people put subglottic stenosis in the other, then we said, well, maybe this should be a choice. And then sometimes some of the answers in the other section were things that we thought maybe actually should have been part of one of the answers that we already had up there. So we would then modify that question so that it was more clear what people were wanting. And I think that it made, it's your suggestions that made us do the changes, because our goal is to generate useful and impactful information. But it's not just what I think is useful or impactful, or what the other members of the database think is useful and impactful, but what you, the members, think is useful and impactful that we want to generate as well. And so this part is just a plug as you go forward to continue to give us feedback, because the way we make the changes is to see what people want and what people need. And the way we make corrections is to have the people, the testers, which is really the users, give us feedback so that we know how to improve. And so I think that the change between version 2 and version 3 is tremendous, but there's clearly still room for more. So as people use it, just if there's any issues at all, reach out to us and let us know, because we want to keep improving. And I think given the support that we have now, it's much, much easier for us to make changes, even in real time. All right, so let me go through and show you a little bit of some of the changes, some of the functional changes. I think one of the biggest things here is that the way multiple admissions is handled is changed. And part of that is because REDCap improved their ability to track multiple admissions, and they made it much easier to do that. And so in the past, we used to have the primary database and the secondary database, but now it's a little different. You have an enrollment form, and that enrolls the patient in the database. And then that rolls over, and then each subsequent admission, which for the first time you're doing it is actually the same as the enrollment, you'd have the core database, the core form, and the expanded form. And then for every time someone comes in, you'll have a new core form and expanded form. So this simplifies it, because it used to be confusing. It used to be hard to track a patient through admissions, and now it's all under one roof, and that's much, much simpler and much, much easier to manage. And then they tried to automate as many things as possible to decrease time and errors. So for instance, you have the protected health information, and whether your hospital is a member of that or is not, is known before, but it used to be a box that you check. So now, since we know if you say you're from Boston Children's, we know the answer whether you should be PHI, so you don't have to answer that question. And we tried to do as many things as possible so that people wouldn't have to answer questions that we could possibly know the answer to. So for instance, the comorbidity information is carried over from one admission to the next. So if you check off that somebody has cardiomyopathy, that we're going to assume that you still have that the next time they're admitted. Now there's a box that says, you know, are there any changes? So you can always adjust it. But this way, it just minimizes the data entry and it minimizes the choice of errors, the chance of errors. And then we added calculation fields for age, for length of stay, and for trach days for PHI sites who are entering dates. So if you say the patient got trached on a certain day and decannulated on a certain day, it can make all these other calculations for you, and you don't have to keep repeating calculations in your head. So I think that this is going to make it much easier and is also going to minimize the chance for error. And then there's just, it's significantly easier to use this database. It was, like I said, the other databases were designed by physicians and nurses and speech pathologists, but this is designed by people whose job it is to design databases. And it's just, it flows so much better. The questions are streamlined. We removed questions that weren't being answered. We tried to consolidate where we could. There's much, much better branching logic so that questions only pop up if they're applicable. If you already said that the person doesn't have a TEP, you're not going to get questions on TEP. And there's checks to make sure that the data quality is better so that you can't contradict yourself within the database. And this lack of conflicting information and the streamlining means I think our data is going to be much more accurate, and hopefully it's going to really reflect what's going on, and the conclusions we draw from it hopefully will be more meaningful as well. This is an example of what I think is the just outstanding streamlining. It used to be that if you were going to go to the expanded data set, you would see all the questions and you'd have to skip them. But now we have the outline here, and you can click the sections you want. And if you don't click them, as you scroll down, you're not going to see them. And I think it's very helpful because part of what we want to do is we want to generate data that can make an impact, right? That's the goal of one of the goals of the collaborative, where we can improve tracheostomy care and the outcomes of trach patients. But if your data is not as accurate, then it's not gonna be as useful. And if people are entering different sections, then you're not gonna have as strong data. So here, by just, if you say for our hospital, we're gonna enter up to here, but we're not gonna enter communication of voice and swallowing and airway, then you're going to be answering the same things each time, and you're going to have more robust data. So I think, and it's going to go quicker, and that's going to make it easier for people to enter data, and that's going to make, hopefully, them enter more data. So I think that really the people involved have done a fantastic job of making the database more functional. And then the content has also changed. We significantly expanded a number of sections. We expanded the pediatric section, and the comorbidity section is highly expanded, cardiovascular part, the genetic part, and this is all due to feedback that we got. People said that we want more data for the peds part, not necessarily for the adults part, but the pediatricians said that this stuff is important and it's useful, and because of that, it's greatly expanded. And the same holds true for communication and swallowing. Here's an example of the swallowing and airway protection aspect, and this is considerably larger than it was before. And again, this is due to feedback that we got that this is important to some of our sites. And same thing, here's communication and voice. There's some other questions that you'd see if you clicked on it, but again, it's much more robust than it was before, and it's much more robust because this is what people ask for. And the advantage is if you don't want to answer this section, you don't click this button and you don't even ever see these questions. So it's very functional and tailorable to whatever your organization wants. Okay, so by far most of our effort and most of our changes had to do with the complication and adverse events. We spent a lot of time working on improving this section, and I think that this is going to be much more functional and much more useful down the road. So we split adverse events into complications and adverse events. I'll go a little bit more into the meaning later on. But we also moved more questions into the core database. So the core database has more questions on complications and adverse events than it did before. And we thought this was important because one of the most important aspects of, of improving trach care is looking at the complications that occur. But then to prevent this from being too onerous, we put extra details in the expanded. And we added the number of events to the core. So now we can calculate true incidence rates per 1,000 trach days. This was, again, something that somebody thought would be particularly useful. And then within the expanded, we streamlined the adverse events outcomes across different type of events so that we didn't have as subjective criteria for tracheostenosis versus tracheal bleeding. We tried to really unify the way we phrased the questions so that we'd have similar outcomes. So the way we defined adverse events is an adverse occurrence is something that's temporally associated with the trach, not necessarily causally related, such as an accidental decannulation. No matter how well you did the trach, this could happen, but they're clearly causally related. And complications are negative events that are caused by the trach itself, such as tracheal stenosis. And I think it's a little bit semantics, but it also, I think it really helps in focusing the questions and making it easier to answer. So here's how we define our adverse events. Here's our complication list. The biggest difference is that we added the WHO level of harm to all of this. So the problem we had, and this is what we debated for a long time in version 2, is how do we define, if somebody says bleeding, how do we make sure that they're saying the same thing as somebody else who says bleeding, and where do you define bleeding that doesn't have a clinical significance, and how do you separate that from bleeding that has some clinical significance from bleeding that has significant clinical significance? You want to make sure that you're not conflating this with this. My kids like anime, so I picked the anime picture. And so the answer is you have the WHO level of harm. We didn't come up with this. This is already out there, and it's none, where no symptoms are detected and no treatment is required. Mild, where the symptoms are mild, the loss of function is minimal. Moderate, symptoms requiring intervention and increased length of stay or causing some permanent harm, and severe. And so we've applied this to all the different complications and adverse events. And so you're going to have a very consistent way of saying whether there's harm. And the point of this is we want to generate useful data that is representative of what's going on. And if someone might label this as bleeding, but someone else might say that doesn't count, that happens after every trach. And so it's the exact same thing, but you might have a difference in the incidence of bleeding. But if one person's has a much higher incidence, but all of it is WHO 0 level of harm, then that this is a difference in reporting and not a difference in outcome. And so I think it's going to make the data much more useful, because we're going to be able to separate the events that are just somebody being very meticulous about recording any bleeding versus bleeding that had harm. And so different institutions will hopefully mean the same thing when they list bleeding as a complication. And then what we tried to do with the adverse events is we tried in the expanded to come up with the same questions for every event if possible. So we looked at first part, we'd have some more detail about whatever that event was. We don't always have that, but if we did, if we needed it, it was there. then what intervention, and then what was the outcome. So for instance, what was the primary cause of the skin issue? Infection, granulation tissue, mechanical. And then intervention, what intervention was required to treat tracheostenosis? A longer tube, a stent, tracheal dilation or tracheoresection. And then outcome, no sequela, outcome of one-way valve placed with cuff inflated. And then we have no sequela, transient hypoxia, cardiopulmonary arrest. So we tried to make these the same for every question so that it was, again, more uniform and our data would be better. That is it for me. I'll turn it over to Josh, and I will be free to answer any questions later on, and thank you very much.
Thanks, Brad, for taking the time to do that very thoughtful recording, and especially the tremendous amount of work that went into the database over a long period of time. I was at a fraction of those meetings and couldn't help but be impressed by the amount of rigor and thought that went into hashing out the adverse events. And ever since the inception of the Global Tracheostomy Collaborative, we've thought a lot about how important it is to look beyond the hospital. And so having that superior improved platform for following sequential admissions is incredibly helpful. So now it's my distinct honor to introduce Joshua Bedwell, who is a colleague and friend, much like Dr. Schiff. He's a pediatric otolaryngologist, head and neck surgeon. His clinical interests include pediatric airway disorders, masses, tumors of the head and neck, salivary gland disorders, as well as improving care of patients with tracheostomy. One of the defining features of our pediatric otolaryngologists is that they're really master of all aspects of the head and neck, and Josh really embodies that. He began his journey to the Global Tracheostomy Collaborative back when he was in Washington, D.C., the Children's National Medical Center, and then led by Dr. Rahul Shah, he and his team were among the charter members and institutions in the GTC and actually put out one of the first feasibility studies demonstrating how the database could be used to accrue data and improve care. He later moved to his current hospital and got promoted when he joined Texas Children's in Houston, Texas. And he shortly came on board with their hospital and joined the GTC. He's going to share his experience helping develop and implement data collection and management teams twice, once at the Children's National Medical Center and a second time at Texas Children's, where he co-leads the tracheostomy team for the largest pediatric otolaryngology practice in the country. So thank you very much, Josh, for joining us and all your hard work. We're excited to hear what you have to share.
Thanks, Michael. That was very kind. So good afternoon, evening, morning. I guess folks are kind of spread out in time across the globe, which is fantastic. I just want to thank the organizers and the webinar committee for inviting me to participate. And of course, thank all of you that have taken the time to join us today or who are watching this later on. So when we think about translating data into practice, especially as it relates to a quality improvement database like the GTC, we often focus primarily on outcomes measures. However, I think looking only at outcomes misses a big part of the story. And one useful way to break this down is through a model of quality and care that was described by Unveiling in the late 60s. It's been around a while. And this Unveiling model suggests that outcomes are the result of the interaction of structures and processes. Structures include things like the physical setting where care occurs, the makeup of the team providing that care, how those team members are educated, and the tools that are used to carry out and document that care, like the electronic medical record. Process is a huge category, including every aspect of the delivery of care. When thinking about process, one way to break it down is to analyze it based on appropriateness and skill. In other words, was the right thing done and was it done well? One thing I found in my experience, both in Washington, D.C. and in Houston here, is that the mere act of formulating and implementing a plan to enter data into a database like the GTC can provide extraordinary insight into the strengths and weaknesses of an institution's structure and processes. I also found that moving a number in an outcome, like length of stay, like moving that actual number may not be as important in the long run as being able to break down all of the components that add up to that outcome, and then working to optimize each of those. In 2015, as Michael alluded to, we published our initial experience out of DC entering data into the GTC database. Now, in version 1 of the database, we were only collecting information on the index admission, or the admission where the patient received the tracheostomy, in what has now become known as the core. This figure nicely summarizes the variables that we aim to capture at that point in time. Now, in order to maximize efficiency, we worked out a system for data entry that recognized the roles of the individual team members and the information about the patient that they would have close at hand. So the ENT fellows would enter the basic demographic information, comorbidities, reason for admission, and indication for trach placement at the time of the surgery. So essentially, after they've done the operative note, they would then enter this basic information into the database. However, since our clinical ENT inpatient team typically stopped rounding daily on these patients after the first trach change, after post-op day 5 to 7, information about the remainder of the admission was then entered by the dedicated tracheostomy nurse. And generally, we found this to be an efficient approach with no one team member spending more than 5 minutes on data entry at a time. We found that a side benefit of this collaborative data entry approach was that there was improved communication between our inpatient otolaryngology team and our tracheostomy nurse. And that improved communication ultimately led to identifying other improvement targets, including the development of a standardized care and education pathway that was ultimately found to reduce stomal complications, among other things. So the important message here is to consider the structure of your team and build your data collection strategy around that structure if it's working for you. And if you aren't intentional in that strategy and developing that data collection and entry strategy, the process for collection and entry will be inefficient and onerous and will probably burn out over time. So now I want to move a little bit away from just the question of feasibility of data collection to get a little bit more granular focus on how that information is obtained. When I moved to Texas Children's, I was floored by just the sheer size of the institution. Texas Children's, as an institution, has nearly 1,000 beds spread across 3 campuses. We, as a division of pediatric otolaryngology, perform about 70 to 80 tracheostomies per year. And at any given time, we have between 30 and 35 trach patients as inpatients. So just a huge endeavor just on the inpatient side. So the data collection process in Houston was going to be much different than what we implemented in DC. The backbone of our inpatient tracheostomy team at TCH is a group of fantastic nurse practitioners and physician assistants who are absolute trach experts. Besides providing education to the patients and families, as well as nurses and other providers, and rounding on all admitted trach patients, our APPs are tasked with collecting and entering data for the database. I want to kind of zoom in on just one data point, and that's accidental decannulation, to show how the act of collecting data can illuminate those structures and processes in a way that can lead to improvement before you even enter a single piece of data into the database. So the slide here is actually an image taken from one of our periodic reports that is sent to our institution by the GTC. And as you see here, this is a list of some of the adverse events, and it kind of situates our site in the context of what others have reported. Now, as we sat together, our tracheostomy team early on, planning out the most efficient and accurate way to pull the data from our EMR, or our medical record, it became clear that we had no standardized way that accidental decannulation events were documented. So depending on the unit, nurses may make a notation in a flow sheet that shows up in one part of the medical record, or they may submit it through by making a note in a nursing progress note, which would show up in a completely other different part of the medical record, or they might submit it through a separate event reporting system that was not at all reflected in the medical record. Or they may do a combination of all three. So clearly, if we wanted our periodic reports, as we see here, to paint an accurate picture of the care we were providing, we're going to need to ensure that that data that we entered actually reflected the reality on the ground. Now, the details about how we went about standardizing decannulation reporting really aren't as important as the idea that analyzing data about outcomes is only useful if you really understand the structure and processes that lead to them. And so what aspects of care do you want to know about? Who is capturing that information? How and where is it being documented? Who's monitoring the data and putting it into the databases? Do they have access to all the relevant information? And can that relevant information be efficiently pulled? These are the sort of questions that we went through as a team as we began our journey with the GTC, and that I think are important for any team to really consider before beginning to enter data. And these questions are even more important now that we have this fantastic expanded database with the ability to capture much more information about patients and outcomes than before. An oft-discussed target for measuring improvement in any sort of inpatient environment is length of stay. And over 4 years or so, our team at Texas Children's has instituted a number of changes, formalizing an inpatient multidisciplinary team, carrying out regular multidisciplinary rounds, overhauling education programs for both patients and families, as well as providers across the organization, and standardizing surgical technique and post-operative order sets and care in my own division. And well, wouldn't you know it, after all of those lovely interventions, we looked at our length of stay and found that we had reduced it, not at all. But in doing a deeper dive into the details on length of stay, as well as another marquee outcome measure, which is in-hospital mortality, we gained important insight into our structure and processes that had led to a sea change in how patients ultimately undergo tracheostomy at Texas Children's. In terms of length of stay, the biggest determinant there seems to be the patient's underlying medical condition, something that we as the trach team have no control over. We did find, however, that there were often significant delays in discharge for reasons having to do with things like ensuring that the home environment was ready, obtaining equipment from a DME company, obtaining and securing home nursing, and ensuring appropriate familial education and support. And this felt like an opportunity. At the same time, we noted a mini trend in our in-hospital mortality. We had 2 patients within a year who were, whose goals of care were shifted to comfort care only within a month after their tracheostomy placement without a change in their clinical status. And one who unfortunately died fewer than 24 hours after undergoing tracheostomy due to worsening of their underlying illness. Breaking these outcomes down, we found that both the structure of the team involved in making the decision for tracheostomy and the process by which patients were selected was deficient. Under the leadership of my partner, Dr. Tiffany Rayner, we implemented a universally applied pre-tracheostomy conference where every patient is discussed prior to a formal consultation by the ENT team. Structure-wise, we widened the net of stakeholders to include not just the primary team from critical care and the surgeons from ENT, but also each specialty caring for the patient, palliative care and ethics, social work, the bedside nurse, and care management. Beyond the ins and outs of the patient's medical prognosis, which of course is a huge part of the conversation, social and systems factors are explored during this conference with the aim of identifying any barriers to quality care and discharge early in the process. We involve families at this early stage in an attempt to provide a holistic picture of the patient's condition and prognosis, the benefits and challenges of tracheostomy, as well as a full exploration of all the alternatives that we can offer. It's too early to say what the effect will be on outcome measures that started us on this path, like length of stay and in-hospital mortality, but our sense is that this conference represents a drastic improvement in the structure and the process of our tracheostomy care. I hope that in this brief talk, I've been able to illustrate the importance of developing a really thoughtful data collection strategy and a thoughtful data use strategy as you approach our new database, either approaching it for the first time or as you're interacting now with version 3. Keep in mind that the outcomes we measure through the database are the end products of the structure of your organization as a whole and your tracheostomy team in particular, and the processes by which you deliver care to your patients. And breaking down how those structures and processes lead to particular outcomes can bring about powerful insights into the quality of care that you're providing and identify surprising targets for improvement. Thanks.
Thanks so much, Josh. That was phenomenal. Thank you also for bringing us back to the iconic work of Donna Bedian. Very early in our journey in Global Tracheostomy Collaborative, we actually talked about the importance of process measures and the structure of care, and how that sometimes, in some ways paradoxically, the parts is almost more than the whole, despite the cliche to the contrary. And you've really been a trailblazer for the organization with what you've done. It's truly a dynasty of pediatric otolaryngology. I've had the pleasure of working with Tiffany as well. And I think that Josh, like anyone on this panel, can be a resource for those of you in the audience. The database is only as good as the database that goes into it and the people that are engaged with it. We have exemplars like yourself, Josh, that have showed us what its capabilities are. Now we're going to bring you to our grand finale with Carly, who is really the data analytics brains behind this operation. Carly has worked at Boston Children's Hospital as a biostatistician for actually a decade. And her experience in clinical research, health services research, and safety and quality has really been incredibly impactful in many domains, well beyond our work in tracheostomy. There were many times in the development of our landmark study from GTC where her work in kind of reanalyzing, cleaning the data, interpreting it really helped us reach some important conclusions about what we had achieved and also where we needed to go. So she basically has been involved with the GTC since 2017, doing work in the Center for Applied Pediatric Quality Analytics, CAPQA, that is housed at Boston Children's Hospital. Her role with the GTC has been data focused to develop and implement the regular data monitoring and comparative reporting processes, as well as updating the database for version 3. She probably has the best understanding of the regulatory and practical aspects of both how data goes into the system as well as how it can be extracted out. And so she's going to actually walk you through both some of the granular aspects as well as some of the high level information about what can be done with big data. So Carly, thank you so much for all of your work and for joining us at this session.
Thanks so much, Michael, and thanks for the opportunity to present here. So today I'll be discussing how the GTC data has been and continues to be used to improve tracheostomy care around the world. I'd like to just start by highlighting that the database is about to surpass an important milestone with almost 10,000 trach admissions entered to date, allowing for valuable insights into tracheostomy care at the institutional, local, country, and global level. The data are used for regular reports distributed to sites as well as academic publications to communicate findings more broadly. And over the next month, we at CAPQA will be hard at work to migrate these admissions currently stored in version 2 to the new version 3. So we certainly have our work cut out for us. So before I talk about some findings from some of our recent GTC publications, I wanted to give a brief overview of how we regularly use and communicate the data that's been entered into the database. So participating sites receive 2 types of reports from the CAPQA team. Quarterly, sites receive a data monitoring report, which consists of logical data checks, which ensure validity and flagging of any high priority missing data that would impact the comparative reports. And this process allows sites to make any necessary corrections before we analyze the data. And the comparative reports are distributed twice per year, and they summarize demographic and clinical factors, utilization metrics like length of stay and trach days, as well as outcomes including survival and adverse events. And an aggregate summary across all sites is distributed along with site-specific reports, allowing for comparison with the GTC performance overall. The comparative reports have highlighted large site variation across a number of metrics, including length of stay, trach days, survival, and adverse events. And these findings could be used to recognize sites who are excelling in a given metric and maybe dive deeper to see if there are opportunities for sharing knowledge with the wider GTC community. Perhaps they've adopted new placement technique that reduced bleeding or created a new patient education program that reduced rates of accidental decannulation. These hypothetical examples demonstrate the enormous value in regular data collection, allowing sites to learn from one another. Regular data entry also allows for the timely reporting of adverse events experienced by trach patients, indicating additional potential opportunities for improvement. And the site reports allow for comparison of your site's case mix and performance to the aggregate performance of the GTC overall on demographics, clinical factors, comorbidities, utilization, and outcomes. And sites may use their reports for internal reporting, benchmarking, and to inform local QI efforts like those that Josh just highlighted in his talk. In addition to the major changes to version 3 that Brad discussed earlier, the database committee also added a number of COVID-specific fields in May of last year. These additions allowed for data collection for both COVID patients requiring tracheostomies and any patients that were living with trachs who may have been at higher risk for admission due to COVID. The semi-annual reports that we distributed last fall actually included a supplementary report for these COVID positive admissions. And although there were only a handful of sites who had entered any COVID admissions by that time, these are important data fields that will allow us to learn more about trach care in the context of the pandemic. And we've started to look at utilization and COVID manifestations for the patients requiring trachs. In 2019, the database committee undertook a large collaborative effort to analyze data from approximately 30 member hospitals that had been entered into the database through the end of 2018. And this was published in the British Journal of Anesthesia last year. And we focused on primary admissions where tracheostomy had been placed for both adult and pediatric patients. We included nearly 4,600 admissions. Most of those were adults, around 75%. And I'll highlight some of the major findings from that paper here. The clinical course was similar between adults and children in terms of their ICU utilization, ventilation, and survival. While adult patients were more likely to be decannulated and the average length of stay in trach days were nearly twice as long in children. Children were also more likely to be discharged home, while adults were more likely to go to long-term care or rehab facilities. And around 8% of patients experienced at least one adverse event related to the tracheostomy, with accidental decannulation being the most common for both adults and children. And trach-related bleeding was fairly common as well, and it occurred around twice per 1,000 trach bed days in adults, which was substantially higher than previously published incidence data, and bleeding events were rare in children. Patients who experienced bleeding also had a higher risk of mortality compared to those who didn't have a bleeding event, even when the bleeding event itself was not directly related to death. And these findings indicated an important area of focus for the future of safer tracheostomy care. We also looked at adjusted predictors of the most common adverse events. So for trach-related bleeding, we found that trach indication and number of comorbidities, as well as some specific comorbidities, hematologic, renal, and sepsis, were associated with higher odds of bleeding events. And accidental decannulation was associated with only respiratory comorbidities. And these findings and the lack of significant predictors for accidental decannulation underscore the importance as an unpredictable, difficult to prevent, and potentially catastrophic event. Another interesting finding that came out of this paper was the vast differences in utilization and outcomes by country. So we found that in the United States, trach patients had shorter lengths of stay, shorter trach duration, lower rates of decannulation, lower incidence of adverse events, and slightly lower mortality. These are likely attributable to differences in practice. Most patients in the US are being discharged relatively quickly and to long-term care facilities prior to decannulation. Our analysis also indicated that their average length of stay was decreasing over time for every month after having joined the GTC. Though for this analysis, we were fairly limited since we could only include sites that actually entered PHI and we had dates of admission and discharge. So we didn't end up actually publishing this, but we hope to explore these findings in the future. And I wanted to briefly highlight another recent publication from the UK, which used the GTC's key drivers and approaches to improvement to evaluate the feasibility and impact of 18 interventions across 20 hospitals in the UK for adult and pediatric trach patients. And this effort was led by Brendan McGrath from Manchester. The results indicated robust improvements in a number of measures of trach care across a very diverse group of hospitals, which was the first of its kind to demonstrate such an impact at such a large scale. After the adoption of the intervention bundle, lengths of stay overall and in the ICU, as well as trach days and ventilator days, declined by 20%. Patient-reported outcomes like depression and anxiety decreased by nearly half. The safety event frequency and severity were also halved, which would translate to nearly 200 lives saved annually if the project was extended nationally. And additionally, costs of care were significantly lower, and wide adoption would translate to a substantial savings of $275 million each year for the National Health Service. So these findings demonstrate the unparalleled value in detailed data collection to improve the quality and safety for patients undergoing tracheostomy. Thank you, and I'm happy to answer any questions during the Q&A.
Thanks, Carly, for a terrific high-level talk of what can be accomplished with this sort of data. One of the things that's really striking is that though that paper was published in June of this year and there was a little bit of lag, the number of cases enrolled was about 4,600, and now we're well over double that. So it really shows how the organization is growing. One of the points also that I think is really interesting is how different our sites are, and those that may look higher or lower on different metrics aren't necessarily doing better or worse jobs. So there are fundamental differences between, for example, primarily pediatric or adult hospitals. But it is worth calling out that there are a lot of really exciting things that we're seeing. So for example, the improving tracheostomy care endeavor in the United Kingdom that Carly was describing, it actually led to a prestigious international award, the British Medical Journal Quality Award. And two of the leads of it, both Brendan and Sarah Wallace, subsequently went on to receive very high honors from the United Kingdom that are nationally recognized. So I think that now I'm going to hand it off to Amy, who's going to take questions from the group as well as has some questions that she can pitch to our panelists. Thank you all for the wonderful presentations, and Amy, I'll give it to you at this point.
Okay, thank you very much. Thank you for a wonderful talk from all of our panelists. Just a reminder, if you've got any questions, to put them in the question box, and I've just got some coming through now. So let me just open that up. So one question in regards to neonatal intensive cares we have from one of the audience. So they know it's a small population, but just perhaps directed to Josh or Carly. So what other neonatal intensive cares are experiencing in terms of management and complications? So in regards to the pediatric literature, is there sort of a regular top series of complications or adverse events patterns that are coming through? Or is that also reported in the paper that you mentioned, Carly?
Some of that would be reported in the paper. I think Josh can probably speak to what are the more common complications.
Yeah, I think, first of all, that population would have been included in the paper, but was not separated out. The pediatric population was not further subdivided between patients from, for instance, the pediatric ICU or CV ICU versus the neonatal ICU. I do think that the NICU population is unique. The indications for trach and the issues that those infants have are definitely unique in the trach population. As far as complications go, I think that in our experience, and this is not something that we've analyzed as of yet, but we are working on it. Complications in the NICU population mirror those of the remainder of the population. So accidental decannulation and particularly tube obstruction are a major issue, given the small cannula and the fact that it's a single cannula for the trach tube. Another issue that we've dealt with recently has to do with the fact that many of our patients in the NICU require higher ventilatory pressures because of bronchopulmonary dysplasia. And so technical issues with the trach tube itself, like cuff failure, are more likely to kind of rear their head. But again, that's not something we've formally investigated as of yet, although it is in process. Not sure if that answered the question.
Hopefully, if the audience, in regards to any further questions you have on that, please feel free to add that to the question box. I've got a question just in regards to, I think Josh and Brad, you both touched on it in regards to looking at the data and benefits for not only the structure, but the wider team in terms of that collaboration with your group, with your nurses, respiratory therapists, speech pathologists, patients, and really, some steps to how you discuss the data. So, perhaps how you actually discuss your outcome data and GTC data. How does that work on a practical level in your facilities? If you can comment on that.
Yeah.
Brad, why don't you go first? I was just talking.
I think that the way it works is, every hospital is different, right? And everyone thinks that they have the most complicated patients, and that's why maybe that would excuse some numbers, and sometimes that's right. But what it forces you to do is it just helps you look at the compared to a norm and say, where are we different? And then it, hopefully you say, well, why are we different? And you can look critically, like Josh did in his example when he was talking, and come up with hopefully with solutions. And so I think, just having the data isn't enough. You really need to look at it, and then you need to delve in and say why. And it could be different for each hospital.
And I think building on that, looking at practice patterns over time, not only compared to other sites, but your own site. How do we change from year to year? And really nutting out those factors of, what's changed in regards to my facility, my practice, and compared to others as well that are similar.
Exactly.
Yeah,
and
I think it's important to, when we get our periodic reports, I will often kind of present it to my division, the pediatric oncology division. But I think you hit on a very important point, which is it's important to discuss it widely throughout the institution, and really, especially with your primary stakeholders in your tracheostomy team, because not only is it helpful to know where you stand, but it's also important in setting goals for the coming year or for the coming time period. What are the things we want to focus on? And as I talked about, what are the structures and processes that are leading to these outcomes that we want to change? So it is important to discuss it widely and not just kind of keep it within one small team or division, but kind of shop that information around, whether it's through presenting it at pediatric grand rounds or grand rounds for your critical care divisions, but really shopping that around the entire institution and identifying people who are interested and going from there.
Yeah, so it's really, has multiple benefits beyond looking at data, but just, not how we performed and where are we going, how do we want to change and why. And in terms of data, perhaps Carla, you can mention this in terms of the benefits of larger data, larger numbers and more numbers. How can that benefit people in terms of decisions? So we saw large numbers of data being entered, so almost up to 10,000. How does that help people, larger data sets compared to just looking at smaller sets?
So I would definitely say the more the better. The more data the member hospitals can enter, the more robust associations we can find when we analyze the data, and just, we'll be better positioned to say something meaningful for these patients.
Yeah. So it gives you a tighter estimate of any sort of effect as well. So it's more close to a true value and not such a wide range. One question that might be out there from the audience is if they're not already contributing data and want to, how do they join? So perhaps Carly or Vincia, could you answer that? So if there's people watching that would like to start entering data, how do they start?
So I think, well, assuming they're already members of the GTC, then they can contact Christine Milano, or they can email CAPQA to be enrolled into the REDCap, so they can access the REDCap database.
Yeah. So sorry, Vincia.
I think the first step is to become a member of GTC.
Okay,
once you become a member, we will give you the next steps in terms of user ID and password. And I think becoming a member involves a lot of discussions about data privacy, data storage, who gets to access, and so on, which are all very important pieces that each one of you and your institutions will be interested in learning and ensuring that these are taken care of. So becoming a member first, and then we will be in touch with you to give you additional information on how to access the database. But if you have specific questions, definitely go to our Global Tracheostomy website, and there's a contact email where you can type in your questions, and we'll be more than happy to set up a time with you to talk about it, or even just respond to you by email.
I'm not positive of this, but I think that actually people can respond to the invites from this, and that will cue them into Christine in our office. And so I imagine that for this particular session, since it's sort of specialized and on our database, we're probably preaching to the converted, mostly active members. But for those of you that are just dipping your toe in the water and might want to join the Global Tracheostomy Collaborative, we would love to have you. And I'll also say that, what we've talked a little bit today about evidence of impact within the scope of GTC hospitals, but we're also very aware of the ripples that the efforts that all of you are making are having further and wider. And actually, even since those papers in June were published, there have been dozens of Global Tracheostomy Collaborative papers, either by the organization and or its members. And I'll even put a nod to a protocol that my co-host Vincia had written a few years ago that related to decannulation protocols. It provided the basis for a paper that was in the New England Journal of Medicine and Altered Standards of Care, and that's been widely cited. And actually, Vincia herself was the first author on a response to that kind of informed subsequent dialogue. So really, there's much that's been in the literature in the United Kingdom, whether it's these studies in British Journal of Anesthesia or in the Lancet. There's been JAMA family work, as well as numerous other places. So we're really grateful for all of you doing the good work of the GTC and the audience, as well as all the panelists. Amy, do you want to field any other questions or final comments from Vincia before we wrap up?
No further questions, but I think it just reflects the true global nature of tracheostomy and practices across the globe, but also across populations. It's not unique to one age, but from every age. And I think it's we've heard some great examples from different centres about how it can be utilised and really look at practice to improve outcomes for patients.
Thank you so much, Amy and Michael and all the panelists for this wonderful session in discussing how we can use data science to improve patient outcomes. So our panelists' contact information are listed here on a slide, but again, as I mentioned earlier, if you have questions specific to your institution, please do go to our Global Tracheostomy website to contact us directly. We will actually send a link that will have a recording of this webinar to you, so that way you can review it again or even share it with your colleagues who may be interested in joining the institution, joining the organization, and also be ready to enter data. For those of you who are new to GTC, please note that you can actually become a member in 3 different formats. One is a patient and family member membership or healthcare professional membership, and these 2 are free to join. And then we also have the hospital membership, which is the one that is required to be able to access the database. So thank you again for joining us with us for this webinar. If you do want to join us, here is the web link, which is globaltrach.org, and then /join us, and you should be able to be in touch with us. Thank you again.
Thank you all, and a happy 2021.
Thank you.